Dr. Narjust Florez.
Thank you, Priyanka, for that wonderful update about what we at ALC have been working on. Now I would like to warmly introduce our distinguished speaker today, Dr. Narjust Florez. Dr. Florez is a thoracic medical oncologist and the Associate Director of the Cancer Care Equity Program at the Dana-Farber Brigham Cancer Center. Dr. Florez is a world-renowned clinician and scientist. Her work focuses on evaluating cancer health disparities and social health justice issues in medicine, and medical education and identifying strategies to eliminate them. She is a PI of the Sexual Health Assessment in Women with Lung Cancer Study, or SHAWL study for short, the largest study to date evaluating sexual dysfunction in women with lung cancer. She's also the PI of several other impactful studies, including the Diagnostic Delays in Lung Cancer, the LEAD study, and the Young Lung Cancer Study, which seeks to investigate the psychosocial needs of younger patients diagnosed with lung cancer. Additionally, she is the Associate Editor for the Diversity, Equity, and Inclusion at JAMA Oncology, and she leads the International Association for the Study of Lung Cancer Considered podcast. It is our esteemed honor to have the opportunity to learn from Dr. Florez today. Dr. Florez will start by giving a 30-minute presentation, followed by a Q&A session that will follow a fireside chat format. And with that, I'm pleased to welcome Dr. Florez.
Hi, everyone. I'm very happy to be here. I'm going to do the best to do 30 minutes. The presentation, we share the presentation with all of you. We are going to talk about a journey of young patients with lung cancer. I focus in young patients today. I have as young as 19-year-old in my clinic. I have a new patient coming on Wednesday who's 22-year-old. So this is a different perspective for some of the presentations you may have seen. So I'm hoping to do this holistically is possible and the time we have allowed. I have several screens, not one, not two, but three. So let me know which one are you seeing, if you're seeing the full presentation or you're seeing the presenter's view.
We see full presentation. Yeah, no presenter's view. Looks great.
So we're going to talk about this journey, which is the journey to improve outcomes in young patients with lung cancer. To have a clear point of what is a young patient with lung cancer are those patients that are less than 50 years. That might play differently to some patients that are some diseases like breast cancer in which young patients are considered to be less than 40. Try to put this camera in the right way so I don't look at you on the side, so you don't think I can give you the side eye, okay? So these are my disclosures. And the question is why Dr. Florez decided to focus in young patients. And I want to invite you all to look at this commentary that I wrote when I still was a fellow, and it's called, Please Don't Tell My Family. And this talks about how stigma forces many patients with lung cancer to unfortunately not disclose their diagnosis and face unique challenges. These women, her real name was not Mary, is what ultimately led to many of my career choices. You always stay back to that patient who changed your life. So lung cancer in women, we're going to talk about women because there's a relationship between young lung cancer and women in which most of the patients are women. The incidence of lung cancer in men continues to decline when women is stabilizing and in some cases is increasing. When you remove tobacco as the primary cause of lung cancer, you can see that 66% of patients are women. So in fact, lung cancer is a disease of women. Why is a disease of women? Because lung cancer is killing more women than any other cancer, and including more other cancers combined, like breast cancer, colon cancer, ovarian, uterine, and cervical cancer combined. More women are dying of lung cancer every day. Lung cancer doesn't discriminate. Doesn't matter if your daughter is a thoracic oncologist. My mother has the disease. She is a never smoker. I was already a lung cancer doctor. If you can take something from this talk from me, is that the only thing that you need is one lung. You don't need two lungs to develop lung cancer. And we need to remove the stigma with the disease because our patients don't need additional burden. So what's happened with young lung cancer? So this is actually one of the New York Times article that has quoted some of my work. And I remember calling my abuelita, which is my grandma, telling her about it. But if you have a grandma who's brown, you know the standards are very high. So she's like, okay, that's good, but where's my great-grandkid? So we talk about the increasing incidence of young lung cancer, particularly in women. Since 2018, we have seen more lung cancer in younger women than ever before. Ages that range as 18. I only see 18 years old because that's the cutoff for pediatrics, but I have some of my colleagues that have seen patients as young as 16. You may have seen some of the videos on social media from some of my patients. So this is the paper that led to a lot of the work that I have been developed, which is the incidence of lung cancer in non-Hispanic white women between 30 to 49 is now higher than men for the first time. This comes from registry data and is irrespective of tobacco behaviors. So what is happening? For the first time in history, younger women are getting more lung cancer than younger men. There are many issues with that, and we're going to talk about it during this conversation, because unfortunately, gender bias is still affecting many patients. So what is happening with young lung cancer? Well, the incidence of lung cancer varies by age. We know that very young patients is around 6.2%, between 40 to 45, 5.3, between less than 50 years, 13.4. We have some preliminary analysis that suggesting around 18% now with the newest statistics of patients are less than 50. And this increased incidence is not unique to the United States. We have challenging diet and challenging behaviors, but it also has been described in Spain, France, Australia, India, China, Brazil, and Mexico, to name a few. Young patients are most likely to be women, most likely to be of Hispanic or Asian descent, and most likely to be diagnosed with metastatic disease because there is no way for screening. As many of you do advocacy for screening, we know that screening starts when you're 50 or older. So let's talk about these incidents. The incidence around 8% in countries Ireland, in China around 11%, and we talk about some of the data in Latin America. But this is one of the things that keep me awake at night, like my new young patient today. Why? Why is this happening to me? I'm young. I think we still don't associate the disease with young patients. And in 2019, prior to the pandemic, the American Lung Association did a study in which they surveyed women, and they asked what is the #1 cause of cancer death. Only 1% of those women reported lung cancer. Diseases like sarcoma and CNS primary tumors have higher frequency in that survey. That was back in the day when we used to stop 1,000 people on the streets. I don't think we do that anymore. So what are some of the unique risk factors? It varies by region. We have tobacco. We have to talk about pollution, household air pollution from solid fuels, residential radon, secondhand smoke. There's also third-hand smoke and occupational exposures. Something that I continue to get to study is vaping and lung cancer risk. Vaping is not part of the cancer screening, but we know that 1 out of 5 teenagers is currently using nicotine vaping. The doses of nicotine are significantly higher in vaping, and vaping or e-cigarettes were developed as a transition for combusting cigarettes. Unfortunately, the transition is not complete for a lot of patients. Data still is evolving. We still have been able to fully manage how we measure vaping use, particularly because there are many, many products. Their products are compacted, the concentration of nicotine changes even within the same device, depends on the cartridges to buy. Some of the additives to this vaping, like flavoring, is hard to measure, and it's also hard to measure how you use it. So we're working to the NCI to try to measure this to identify the risk. The main thing is that people that have regular cigarette use, around 10.3% don't transition and actually became dual users. We do know there is less exposure to biomass with the e-cigarettes, but the risk is not zero. So we recommend a full transition, and the e-cigarettes should be a temporary situation. It's not like one versus the other. We do know that the withdrawals for e-cigarettes are significantly higher because you have higher nicotine. And also has been different perceived, right? If you smell somebody using cigarettes, you can see somebody's like, ooh, you smell bad. But now the e-cigarette smells like apple or gum or whatever. So the stigma, the social stigma that's stirring away people from tobacco use, regular tobacco use, may not exist with e-cigarettes. I was doing my pre-wedding photo shoot on Saturday and Friday in the Dominican Republic, and the photographer pulled an e-cigarette, and I was like going at it. I was like, no, you're not using that around me to do what to do, because we still don't know. Cannabis, there's a lot of questions about cannabis, and we still don't have a full answer. But we do know that the combustion of the cannabis is more dangerous than the ingestion of the cannabis. So edibles and tinctures, there are several meta-analyses that has been conducted in which may be an increased risk, but it's still inconclusive. Why I'm talking about this? Because this is what young patients are asking us in the clinic, and I want to know, with the legalization of cannabis, what is the risk? So not combustion, nothing that is burning should go to your lungs. Pollution is a real risk, particularly for women and particularly for high polluted areas. We have seen an increase in India and China and big cities like Sao Paulo. And this is associated with induction of cell genomic instability. And we know there's a relationship between new oncogenic mutations and PM 2.5. So there's a relationship between these two, in which we know that these women and men tend to have more oncogenic driver mutations. They have no previous tobacco use, but they have pollution exposures. And one of the challenges about pollution is how to measure where you live and how you do it. But we're still studying this. There have been more studies in China, and there's a new study that we're hoping to conduct in Monterrey, Mexico, in which we have seen a high incidence of young lung cancer. We just came back from Mexico to evaluate that. It may be related with the radon and the mining in the area. So young lung tend to have a epidemiologic aspect. We also have increase in wildfires, and how is this increasing and affecting the air in many areas? We see now wildfires and the Blue Hills here, right? There was wildfires in Brooklyn. It's Brooklyn. So wildfires are becoming, I think that's affecting everywhere. It's no longer a California issue. We see changes in our air from the wildfires in Canada. Radon. Radon is still the #1 culprit of a lot of the young lung cancer that we can identify. And radon comes from many parts in our house, and particularly from the soil. And it's important that we continue to check the radon levels, not only when you buy a house, but afterwards. So everybody here, ask your parents, when is the last time you checked your radon levels at home? Please. Your parents may have checked the radon levels when you bought their house before you were born, or in the 80s. So it's very important this continue to be checked. What about family history? The IAS association with family history is still to be determined. Here's some of the susceptibility genes. The inherent study that's being done by Dr. Lopiccolo here at Dana-Farber is trying to evaluate this in further detail. The Taiwanese study is a study that evaluated, many of you would be familiar, lung cancer screening and never smokers, no tobacco users. We don't use never smokers, it's stigmatizing. No tobacco users. And they find out that a strong family history, particularly for EGFR lung cancer, was associated with a risk factor, even in the patients that didn't have the germline mutation for EGFR. Just having a family member with an EGFR mutation was found to be a risk factor for lung cancer, even higher in some cases than 25-year history. So we know that family history matters in lung cancer, particularly for young patients. Some of my young patients today, at least 2/3 of them have some history of family history of lung cancer. But it's important to take into account a confounding factor, is that some of their parents may have used tobacco and they have exposed them as children to secondhand smoke. So there's always some more why. All right. One thing we need to take into account is that there is no lung cancer full prevention. It's risk reduction, because risk reduction sometimes is affected by equity. We talk about radon, right? For low-income families that live in subsidized housing, they don't have the privilege of measuring the radon. Some of them, they live in apartments. We did a study in Milwaukee in which some of the subsidized housing never had radon measured. So it's a matter of equity. Secondhand exposure is also a matter of equity, particularly gender inequalities. Women are 58% more likely to be exposed to secondhand smoke, particularly in the years before the 2000s. Women were more likely to have flight attendant jobs, jobs as servers, jobs as bartenders, and secretaries. I have 4 flight attendants. They never used tobacco themselves, but they were exposed. Construction workers, a lot of immigrants that may have limited educational level or limited language proficiency work in construction, and that's a direct association with radon. So it is a privilege to have an office job. And pollution, you may not be able to move. Chelsea is one of the most polluted areas we have in Massachusetts, but it's also low housing. Those families cannot afford somewhere else. So remember that risk reduction has a direct link with equity. So why is young lung increasing? We don't know. It's most likely to be multifactorial. And like this cartoon, many reasons. But what are we doing to understand young lung? Now is the fun part. Let's see what the Florez lab is doing to understand young lung. One, this is my biggest, longest birth baby. What is birth baby? Because this is a 12-year study called the Epidemiology of Young Lung that we launched in 2022. This study evaluates patients less than 50, and we're doing a full evaluation. What exposures they have, we're doing genotyping wherever they live, measuring the pollution level there, family history, diet, physical activity, and we're interviewing their mothers for even any in-fetus exposures. So we're really hoping to do this. We have 202 patients, and we're going to continue to follow these patients prospectively. The questionnaire is 200 questions, so I'm very thankful to all patients that have participated on this. And we also are collecting blood. We have at-home blood draw that is being done to evaluate any potential risk factors and genomic characteristics. So we hope that we continue to learn. So far, we have learned that we didn't find an association between diet and physical activity so far, and we'll continue to do this. This is a US-based study, and it's a 12-year study. So 2 years down, 10 to go. Hopefully I don't, leave academia before I finish this study. I want to share a story of one of my patients. So I'm going to share her story because it will be related to some of the studies we do. Can you hear it? Alex, give me the tone.
We cannot hear it.
No?
Mm-mm.
Okay, so I may have to stop sharing and share with sound now. I'm on it. Share sound. That was the issue. Okay. Go back to the regional plan. Let me know, Alex. Everybody,
Yep.
you may have to turn up the volume. All right, let's do this.
Hi, everyone. My name
You're good. Yep.
Because you need to hear from patients, not only from me.
Hi, everyone. My name is Aurora Lucas. I am currently a 31-year-old lung cancer patient and advocate, but it was actually 2 years ago that I was diagnosed with lung cancer. It was on December 6, 2021. 3 months prior to that, which was September 2021, is when I began to feel the symptoms in my body. And when I finally decided to go and meet my primary care doctor, what he did was that he saw me and said, "You look pretty good. Yeah, like you're coughing, your back might ache, but go home, boil some water, add some honey, and you're gonna be fine." And I didn't know how to speak back or raise any questions. I was like, "Are you sure?" Like, that is all I said.
So that's a story that is very, very common with women. Unfortunately, they continue to be told that it's anxiety, there's many symptoms because we still don't associate lung cancer.
Hi, everyone.
Patients. These are some of the things that my patients have heard. You cannot have lung cancer, you're too young for that. Is anxiety? Here's a prescription for Xanax. I actually have a patient that had created these hats for other young patients that says, it turns out it wasn't anxiety. And in the back of the hat, it says it was lung cancer. And there's also bias when it comes to minorities. You were born in Haiti, this must be tuberculosis. So secondary to this, we opened the LEAD study in order to understand the journey of patients with lung cancer and to identify if there are differences by tobacco history and by age and gender. The LEAD study was supposed to recruit in approximately 12 months, but we recruited in 4 months. And this is in collaboration with NGH, and is to determine if sex and age differences exist from the symptoms onset to the time of diagnosis. Our hypothesis is that younger patients and women have significant delays in diagnosis. And we also needed to identify where some of the system-level clinical barriers to the lung cancer. And you may know somebody from this picture, part of the LEAD study, but Dr. Yan has been part of the LEAD study that finished quantitative data analysis, and now we are proceeding with the focus groups. Very, very fortunate to have this amazing team for LEAD. So what we have learned, first, gratitude. Many of the patients are very thankful that we're evaluating this. We recruited in very record, so I needed to pivot and change the timeline for 8 months. Many of them reported that they have diagnostic delays, and the challenges moved even and affected their family. Many patients reported they didn't have no idea about lung cancer, and that many of them couldn't even say as much as they wanted in the survey. Usually we get around 10 to 15% wanting to participate in clinical trial and focus groups. We have 90%. 36% of them have no previous tobacco history, very different to what is estimated to be 15%. 41% of them reported direct history of lung cancer, which supports some of the data. 89% discussed never having a discussion with the primary care doctor or healthcare provider about lung cancer. And this is very important to you. Many of the patients that qualified for lung cancer screening were not offered the opportunity of lung cancer screening. What we did learn is that the stigma has significantly improved, only with 17% of patients trying to keep this a secret. Around 1/3 of the patients were diagnosed due to symptoms, but 56% of them were diagnosed by incidental finding, but only 10% by lung cancer screening. We can do way better than that. 31% of them felt they had significant delays in diagnosis despite seeking care. This data is unpublished, so unpublished and such. So some of our endpoints include symptom onset to primary endpoint, which is the biopsy. Other secondary endpoints include imaging and treatment initiation. What we have seen so far is that a woman average is 6 visits to get a lung biopsy, when the male patients had averaged 2 visits to a lung biopsy when cross-matched for symptoms. So, time is running very quick. So what happened with LEAD? We are expanding to LEAD. We open in Duke. They're almost finished with recruitment again. I think I need to hurry up things. We are opening a national LEAD survey to the lung cancer registry. We have experience working to the registry when we conducted the largest sexual health assessment in lung cancer, the SHAWL study. So we are moving to open the LEAD questionnaire nationwide. But one of the things that has led from LEAD is the national campaign that you may have seen in social media, which is the Hear Her campaign. Because in the questionnaires of LEAD and the open questions, what we learned from women is many of them seek medical care, but their complaints or their symptoms were not taken. The appropriate steps were not done. So we have launched this campaign. You may have seen these beautiful pins. One of the pins was designed by one of my patients, and it's called the Hear Her campaign, or Escúchala, which is to improve awareness about lung cancer in women. We have distributed nearly 2,000 pins. And 2 weeks ago, I was in TSA, and one TSA agent asked me about the pin, and I say what it was about. And he's like, oh, my mama smoked. And then as I'm leaving the pre-check TSA, I hear him in the phone calling his mama and saying, Mom, you gotta better check your lungs. I heard a doctor say that if you smoke, you need to get your lungs checked. So if you don't have PIMS, we still have some. Happy to send some for you. And they're beautiful. They're beautiful. The butterflies honor the women that are no with us, that we fight for, and the flowers mean hope. So what's going on with diagnosis for young patients? Well, they're excluded for lung cancer screening, as many of them that had no previous tobacco use. Many of them are diagnosed, unfortunately, when they have symptoms that suggest many of them have metastatic disease. Physician bias that young patients don't get lung cancer. And what about family risk? So this is our next study. We do a lot of things. I never know how much stuff we're doing at the lab until I put presentations like this together, which is our EQUAL study. Our EQUAL study is our new baby, soon to be open, and is to evaluate EGFR, cell-free DNA to diagnose lung cancer in patients at risk. These patients don't qualify for CT scans for lung cancer screening, so we're trying to develop a blood assay that will help us diagnose lung cancer, particularly in women of East Asian and Hispanic or Latinx descent, particularly because all of them are ineligible for a standard lung cancer screening. This is in collaboration with the Belfort Center, evaluates only common EGFR mutations. We have a specificity preliminary of 100% and a sensitivity of 71%. It's only one tube. And we're going to have 2 cohorts. Sorry to move fast, but we're running out of time and have a lot of things going on. We're going to do the blood draw and an intake questionnaire, and we're going to try to evaluate what is the uptake of this type of screening on patients, particularly populations of color. But EQUAL is the perfect joint between my young lung efforts and my cancer equity efforts. It focuses on populations in need, as well as patients that are young with family history. So this is my team, the beautiful team for EQUAL. We are one IRB approval, waiting for recruiting the first patient. We're ready. You know, when you have a party at your home and you party and you have the cake and the snacks and the drinks and you're waiting for the first guest, that's what I'm waiting for this IRB to give me approval because we're ready to go. So we're going to do the assay, but we're getting 2 tubes because we're going to validate the assay in a CLIA approved test. If the test is positive, the study is going to cover a free CT scan in these patients. If the CT scan is negative, the blood assay was positive, we're going to follow up in 12 months. We are repeat CT scan, and we're going to help navigate patients to diagnosis. Plus, we are working with the community. We're going to do recruitment in nail salons, barber shops. We're going to go. I never had met with that many religious leaders until EQUAL. We're going to go to events, but it's dedicated to Asian and Hispanic patients. 50 to 80, we know previous tobacco use, more than 400 cigarettes in a lifetime, and family members of EGFR positive patients. Also, we also don't know the unique characteristics and need of young patients because they're new. We are new to them. So we're trying to understand what are their psychosocial and financial needs. When you're a young patient with lung cancer, you are part of the sandwich generation. What this means, you care for your children and you also have to care for your parents. So who cares for the caregiver when the caregiver gets sick? So we conducted the largest study on young lung, particularly for psychosocial needs. This is the first one, and this is the first one to evaluate financial needs. Okay, financial toxicity is a side effect of cancer care. The studies were presented at ASCO for the survey part of the study. What we saw was high prevalence of mental health issues in this population. We had a control cohort which is older patients. These presentations is not meant to go on every detail or studies because we will be here until tomorrow. But we have high prevalence of mental health issues in this population. For that reason, now we're partnered with a psychologist at Dana-Farber disease or patient, specializes in younger patients, Dr. Christina Pozo-Carmen, high financial needs, significant higher financial toxicity for young patients compared to older. Many of them had negative experience with the healthcare system up to diagnosis. And the difference changes by gender. We higher social needs in women. So 40% reported having any or little money available to pay for lung cancer treatment, 40%. And 55% had little idea how much they were going to spend in treatment. 35% felt considerably financial stress and reported there was a significant financial hardship associated with cancer. And half of the patients reported that they don't really have a plan about financial plans and how they're going to cover treatment. So financial toxicity was very high in these patients. So why are we doing? Well, at the Florez lab, we love our data, we publish our data, but we love believing, we love creating solutions. So the consequence of lead, we have the here, right? We're not listening to women. So now there are 2,000 things out there for people to associate lung cancer with women. Young patients have financial toxicity. So for the first time this year, we started the Jimmy Fund Young Lung Cancer Walk. We're able to fundraise around $30,000. Dr. Yan funded also part, help us there. Everybody, my uncles, everybody was getting a text message, $20. And we actually won Rookie of the Year for the Jimmy Fund. And all these funds are being used to support the financial needs of young patients. This includes gift cards for transportation, gift cards for Stop and Shop, for groceries. Because we believe in solutions. Yes, the healthcare system has challenges, but also we're in the ground. We have fundraised. We have $35,000 that we hope help our patients. 2 weeks ago, a young patient that is not under my care didn't have enough funds for gasoline for her scans. We figured it out. We found gift cards for gas stations close to her house. We were able to help with that, and she made it to the scans. So we're doing a lot of much work, no time for this. We're evaluating the fertility effects of targeted therapy and immunotherapy. This is called the Finch study. We also launched the first pregnancy and lung cancer registry as increased incidence of lung cancer in young patients. We're seeing increased cases of lung cancer diagnosed during pregnancy. I get an email now every week, and that's scaring the hell out of me, to be honest. I already got the email for this week, so hopefully I don't get another email. No, because I don't like to help. I love help. It just scares me that more pregnant women are being diagnosed with lung cancer. I'm actually going next week to the pregnancy conclave. So if you know, the conclave is when everybody gets into the Sistine Chapel and they pick the Pope, right? White or black smoke, regardless of religion, everybody is put together in a room to make a decision. So for the first time, lung cancer is being included in the pregnancy and cancer conclave. They against me, now for the first time, we're going to upstate New York. We're all getting in this place, and we're writing the updated guidelines about cancer and pregnancy. And for the first time, we're going to have a section about lung cancer and pregnancy. So when you feel that the work you do, somebody doesn't matter, for the first time, pregnancy and lung cancer is going to be in the guidelines. So if you're, sometimes I'm discouraged, and sometimes I'm like, oh, these people don't believe in young lung cancer, nobody's listening to me, then it's going to be in the guidelines, and I'm going to be with the conclave. I don't know how it's going to go, never been there. Thank God my mentor is going to be there because she does pregnancy and breast cancer. This is my last slide, almost to last, is young lung cancer has delays to diagnosis, negative experience with the healthcare system. Biomarker testing is very important in these patients at all points of diagnosis and progression. These patients are most likely to have aggressive treatment, more likely to have side effects, so we have to provide extreme and extensive support. high psychosocial needs and financial toxicity, high prevalence of sexual dysfunction and fertility needs to be studied in these patients. So we're in that journey with the Finch study. And finally, I want to show you how lung cancer looks like. These are the many phases of young lung cancer. To all of you on social media, please go on Instagram, Twitter, I'm never gonna call it X, or Butterfly. What is the name of the Butterfly? It's still new. To follow the Young Lung Cancer Initiative. This is an amazing nonprofit that focuses on creating awareness about young lung cancer, and we're very privileged to work with them. So there is hope. We will continue to study young lung cancer, and we're going to continue to scream at our lungs that lung cancer is a disease of young individuals. This is only the tip of the iceberg. Hope you have a sense of what we're doing, what is happening. Couldn't talk about everything. And most importantly, what you do is better when you do it with a group. This is my reason to be in academia, and it's my lab. These are the many members of my lab. Many of them are faculty. They studied with me when they were residents or medical students, research assistants. I have now 2 that are actually in medical school, and 1 that just got accepted in 2 medical schools. So we are better when we do it with a village. And I'm so proud to call them my village. So thank you so much for your time. Alex, sorry I went over time, but there's so much to talk about.
No, this is absolutely amazing. We're just so grateful for your time and so inspired by everything you talked about and taught us today. And so now we're going to transition into the Q&A session. It'll be in a fireside format. Sonia from our team is going to go ahead and lead it. So I'll hand the mic off over to her. But just wanted to thank you again, Dr. Florez, for wonderful presentation and for taking the time to be with us here tonight.
It is my honor. You guys all, ladies and guys, motivate me to continue to do this because the future is bright. And what Jeff and I doing is not going to die. It's just going to continue to expand over time. And we're going to be in our rocking chairs, and we're going to see you all talking about lung cancer screening and young lung later.
Thank you, Dr. Florez, for your outstanding presentation. I know I speak on behalf of our entire audience when I say we are so thrilled to have the opportunity to learn from you, and want to thank you again so much for the time and for speaking today. We'll now, as Alex said, transition to the Q&A portion of the lecture, which will follow a fireside chat format. So today our audience ranges from high school students to undergrad students to med students and even physicians. So we would prefer that you ask your questions verbally, but of course, please feel free to use the chat if that is more comfortable for you. And if you would like to ask a question verbally, then please use the raise your hand feature. And I'll start us off for the first question. I see we already have some people lined up too. So kind of going back earlier in your presentation, I was just wondering, given that vaping and e-smoking have become much more socially acceptable, or at least less stigmatized than smoking tobacco, and that many young people are hearing the messaging that vaping and e-cigarettes are safer than smoking tobacco. Dr. Florez, how do you advise that people go about having conversations with young people that vaping and e-cigarettes can still cause lung cancer and they're still risky? And what suggestions do you have to change messaging from a public health standpoint that you think will help get that communication across?
So the data hasn't been streamlined like we have seen it with tobacco. But the data wasn't streamlined with tobacco either at the beginning, right? In the place that I trained, they used to prescribe tobacco for hysteria for women. And we have come a long way from that. So I think the clear message is nothing that is any type of combustion, any type of air belongs to your lungs besides the air outside. And the air outside is still questionable, right? Because of pollution. So it is safer not to put anything in your lungs. There has been some evolving data, but I don't have a say, if you use e-cigarettes. But what we do know is that e-cigarettes can lead to also initiation of tobacco use in some populations, right? So you may start with the e-cigarette and then you will switch to the tobacco. It is less biomass exposure. Yes, we do know that. It's also hard sometimes to advocate against the use of e-cigarettes because these people on social media come and attack me. That has been before, and I will do it again. It's sometimes fun. but I will not recommend it because of the unknown risk. We don't know that produces inflammation on the lung, and inflammation is a precursor of cancer, right? So any inflammation produces increased cell proliferation, and that can lead to cancer. So I won't recommend it. Unfortunately, we don't have the thing of you're gonna get wrinkles because we don't know that yet, but I think I will reduce that. And also the withdrawals for vaping and e-cigarettes are awful because you are a high dose of nicotine. I don't want to use the brand, but I have to. The dual cartridge, one cartridge, some of them high concentrations can equal up to 3 packs of nicotine use. And it's very hard because there's so many globally. That is hard. When I was in the Ukraine for different reasons, for medical mission reasons, you could order the e-cigarettes in a restaurant, like you order French fries. So in the US, and it's a global phenomenon, unfortunately. So no, inflammation, bad for you.
Thank you. It's a wonderful
Clear
response.
message.
Thank you. And I think Dr. Keys has a question as well.
Hi, Colleen.
Oh, sorry about that. I couldn't unmute. Amazing, amazing talk. I have kind of 2 hopefully short questions. The one is passion. How did you find your passion? I think for some of the younger generation here, obviously we all feel very inspired by you. How did you have the beginnings? Like, how did you develop this passion in your lab? And then the second one is a little bit more related to trying to figure out how we get a message out there on avoiding these prolonged times to diagnosis for women specifically. Are there any lessons that we could learn, for example, from breast cancer screening or anything like that?
Yeah. So I think the passion started with Mary, but what keeps your passion is that continuous flame and events. I don't think there's something that will always be light up. So it started with Mary when she trusts me about her diagnosis, but she wanted me to keep her secret. And then unfortunately, when she died, her obituary say that she died of breast cancer. And that broke me, Lynn, that broke me. I cried so much because it was so unfair that she dealt with this cancer for 2 years. And even at the moment of death, she needed to hide it. So then I started treating young patients, and I needed that. I felt that it was the perfect match because I do know who Cardi B is. I know what TikTok is. And we could connect to a level that is important and what matters to them. Like last Saturday, one of my patients want to propose. And I was more excited about that than doing cake tasting for my wedding because he had a complete response in this RET inhibitor. He was misdiagnosed somewhere. He came to me, complete response in a RET inhibitor. He bought the ring 6 months ago after the good scans. And I say, let's wait, make sure we have good scans. And this is not a matter of emotion that you really want to propose, right? That is my passion, making my patients have accomplishment. I go to the Boston Marathon every year because I have patients running there. Today, I have 16 patients. I'm not tired because I was able to see them and see them go. I got another wedding invitation today. So your passion continues to be light up by these moments. And even in the difficult times, you know you are the right doctor for that patient. Because I'm the right doctor for that patient. I was in Colombia for Latin American Lung, and there was a family meeting for my patient, and I was like, I own it to them. Even in the bad days, I need to be there. And we figured it out with Zoom in a tablet, and I was there. So I think that knowing what they need, not always knowing, but I have an idea what is important to these patients, keeps me going. And the good scans and the bad scans, because I need to be there for the bad too. And for the pregnant patient, I have to be honest, everybody's like, oh, you do that. Because I see all these babies. Because these women are given the option to keep their pregnancy. Instead of being told they have to terminate the pregnancy, that's the only option. So I have pictures of all these babies. And today I have a 2-year-old come to clinic. And I was like, I came with this baby 3 times. And then she's like saying mama and playing with everything. So that keeps my passion. about increasing awareness. That's what we're trying to do. We hear her to increase the awareness. We're also have now is being picked up by news platforms, and we have reached out to celebrities. Thank God, Instagram. So after Lung Cancer Awareness Month, we're gonna start another campaign with celebrities about that because we want to make sure the momentum continues. I also go every year to ACP and every year to the Family Medicine Physicians meeting to talk about lung cancer in women and young patients. And it's not the point of you are doing this, I'm doing that. The point is like, hey, this is what's happening. Not like, oh, you didn't do lung cancer screening. Because many of these patients don't have the age cut off. But it's mostly about, hey, you don't see this, I see this. This is what's happening. So I'm going to ACP next year in New Orleans, already booked, to increase awareness. Because we are partners. It's not like the oncologist, oh, you didn't do as a primary care doctor. No, we're partners and we work on this together. My mom was told she had cataracts, Colleen, and it was choroidal mets from her lung cancer. So that's a wake-up call. I was already an oncologist at Dana-Farber that doesn't discriminate. So, and she actually opened the World Conference on Lung Cancer this year. Nobody knew my mother had lung cancer because she didn't want to tell people. So as a very proper Latina, she just announced it to 5,000 people live. So go big or go home, right? That's my mom. She just moved back to the Dominican. Thank you for your question, Colleen.
Yeah, sorry, Sonia, were you gonna go jump in?
Yeah. Thank you, Dr. Florez. I think our next question is Alicia.
Hi, thank you so much for taking the time. I was just wondering, obviously a lot of the outreach we do focuses on people that are at least 50, so that they fit the eligibility criteria to get screened. Do you have any like advice or suggestions or anything that you've had in your experience of kind of like next steps to give people that might be younger that don't actually fit the criteria to get screened?
So we're doing all these studies to understand exactly where the cutoff is and where the risk factors. So another thing I'm doing, I have partnered with MIT to try to create these algorithms for other risk factors added for lung cancer: previous breast radiation, previous family or EGFR, previous living in a high pollution area, to see if we can come back with like this is the ultimate goal, is to correct with a calculator that will determine risk. But that data is still very, very new for me to do that. But that's what we're trying to do. But the most important thing is awareness that if you have any respiratory symptom that doesn't get better, ask for imaging. After a course of antibiotics, you need imaging. You need imaging. And I think as young patients, we're not used to advocating for ourselves, right? So we need to advocate for yourself when in doubt. I had a patient in the healthcare system. She's new. I just talked to her today. She had a brain lesion and I started her in the drug and they were going to irradiate her today, but the brain lesion is gone because the drug is so good. She didn't get hurt for months. So she walked into the ER and she's like, I need imaging. And she was diagnosed. Disease is metastatic, but at least we're able to identify it kind of early. So advocating for yourself and encouraging people around you. And when you go for medical students, for residents, when somebody talks to you, listen beyond that. We have been taught to put people in boxes. That's how we take our exams, right? Step one is an 8-hour exam with 150 questions. So you learn by people put it in boxes. But lung cancer in young patients has taught us that that is not the case. Not everything is lupus, like House, right? Like the show House. And by the way, we don't do chemotherapy. Imperative. But yeah, I think go beyond the no. I would say go beyond the no and teach people awareness about going beyond the no.
Thank you. And next we have Deepti.
Hi, Dr. Flores. Thank you so much.
I know
Every time we hear
you,
from
girl.
you, it's like you expand our entire horizons on what we see and how we perceive lung cancer. You answered almost all of my question in your last answer, but I was wondering, in the past like 3 weeks, I've been at 3 different outreach events, and someone at these outreach events have come up to our table and said, I'm not 50, I don't qualify for screening, but I'm having like shortness of breath or having some symptom. And I went to my doctor. I want them to get this scan, and they won't do it for me. I've already talked to them, and I don't feel heard. Do you have any advice on like how we can encourage them to kind of keep going, or someone else they can go to if their primary care doctor isn't listening to them, on what they can kind of do next after that? No.
Yeah, one of the challenges is that we're in significant shortage of primary care doctors. I have a patient right now that's waiting at Brigham for a primary care doctor, but I was able to find her an electrophysiologist in a week, but I wasn't able to find her a primary care doctor in 4 months, right? So we are becoming more and more specialized, and primary care doctors are becoming in shortage. My first answer would be go and find somebody else, right? But if the symptoms persist, urgent care is an option too, because they may get further imaging. If you still have symptoms, if somebody comes to you, you cannot provide direct medical advice, but I would say we recommend you to talk to your healthcare provider. And if you don't feel comfortable, consider another healthcare provider. That may not be the full answer, the appropriate answer, but I think sometimes that's the way that I have found patients to be diagnosed. Because it's very hard to get primary care doctors, sometimes urgent care. The Early Diagnostic Center, INGH, yes, by Dr. Sick with 100%, but they have to have imaging to get in there. They have to have imaging, right, Jeff? To be able to get in, they have to have imaging to get into Lisha's program.
I think it could just be referred there.
Okay.
I'll need to double check that.
Yeah, because the cancer diagnostics clinic at Farber, you need to have imaging. And the problem is getting to the imaging. So sometimes urgent care has been very helpful. We're getting an x-ray or getting something else. But it's common. This is the problem, their own hair. And sometimes it's not lung cancer. I just diagnosed TB, but I found that was easier way to get her into my clinic because she has so many obstacles through the cancer care equity program. Another thing is to look at the federal qualified clinics. So in Boston, we have, like, I'm the associate director of CCEP. They can also be seen as the cancer diagnostic clinics. And I will send you the information. In Jamaica Plain, Dorchester, and soon to be Lawrence. So if they have concerns, they can make appointments to CCEP, and it works as a cancer diagnostic clinic. We had a 22-year-old that we are having issues, and I say, you know what? I'm taking over. And it was tuberculosis, but we needed to figure it out. I will send you the address tomorrow because it's 8 p.m.
That's incredibly helpful. Thank you so much.
Yeah, CCEP, free of charge.
Thank you, Dr. Flores. We were wondering if we could go 5 minutes over time just to get through the next few questions. Thank you. And I think, Lucy, if you would like to go next.
Yes, hola, doctora.
Hola, ¿cómo estás?
Bien, gracias. It's really nice.
You just send me an email so I can send you Latinas in Medicine gear. That's my other endeavor.
Oh, you're so
put
sweet.
It in my presentation. That's my nonprofit that has 10,000 members to encourage and amplify Latinas in medicine. That's my other thing. Colleen and Jeff, I think I may be doing too much, but yeah, send me an email if I can send you some gear.
Yes, my comment was on I'm a PhD candidate in public health sciences at UC Davis, working on understanding the barriers and facilitators to lung cancer screening. And it's just so refreshing and inspiring to hear another Latina in the field. And the work that you're doing is really amazing, and I really love it. I did have a question regarding your 12-year study. You mentioned looking at where patients, doing like a spatial analysis on where patients live. I was wondering if you were also going to take into account where they work, because what I'm noticing is that, or what I'm reading in some of these articles, is sometimes people are where they work, they might have more exposure to where they live because of how much time they spend.
Yeah, we're looking with the work and the type of professions that evolve over time. We have noticed in young patients that are very young, they tend to work in factories, and as they get older in their 40s, they go into more office, right? Equity. So we have seen that. and particularly in areas of Southern California, we have seen that transition, particularly for first generation.
Mhm.
And we've seen it in the Midwest as well. So we are taking that into account. It's a 200 question questionnaire.
Yeah.
And yeah, that's what I think is struggling has been recruitment, but we do it, we have to do it well. And in the study I'm going to do in Monterrey, we're going to the mine workers in Monterrey.
Yeah,
There's
that's
a lot of mining there. And 18% of all lung cancers in Monterrey is ALK positive. We don't know why. We're going to try to find out. And one thing, Lucy, be 200% Latina. There's little PhDs that are Latinas. When you feel that you don't belong for some reasons because people may don't sound or look or don't have your experiences, remember you bring something to the table. That is your background, your understanding of our population, and 1 out of 5 US humans living here will self-identify as a Latinx in 2030. So you belong in medicine, even if there's not many PhDs that be Dr. Rios, but you are opening the door for more. Okay.
Yeah, yes, I appreciate it.
And the hoops are completely professional, and bright colors are professional. But we dress in certain form. It just comes a way of trying to minimize who we are and try to put us in a box. But when I have a problem, I'm going to stand up to show you my dress because it's a very traditional Mexican dress that I got as a gift. So,
oh yes, it's so beautiful.
It's super long and super big. I can dance tapatio with this.
Yes.
If I want. But the point is that everybody needs to be their true self because we bring something to the table. Sorry, you guys didn't want to see my dress, but I need to show it.
I love it. Thank you so much.
Thank you, Dr. Flores, and that's a beautiful dress. Thank you for showing us.
Yeah.
And I think
it's also good when you are bloated. Doesn't look anything. That happens after vacation.
Absolutely perfect. Our next question is Dr. Zhu.
Thank you so much, Dr. Flores. This is a fantastic talk. I had 2 questions, and I'm sorry if we don't have enough time, that's okay. But my first has to do with the 12-year study. I may have missed it, but I was wondering if you have seen any preliminary, very interesting results in the epidemiology of young lung cancer patients. And my second question had to do with the patients who have lung cancer in pregnancy. I think that's a population that I forget about a lot of the times, and I feel like with younger patients they have EGFR mutations or ALK positive mutations, and how are they? Are they candidates for things like alectinib or osimertinib, or are they unfortunately not candidates because of that pregnancy?
So let me step back to that question because that's a very important question. So target therapy is extremely dangerous in pregnancy. I have seen the other side of that, particularly ALK inhibitors. As you know, the ALK pathway is essential for neural development, right? So when we use a ALK inhibitor, particularly early in pregnancy, we have seen significant neurologic disorders, congenital disorders in the fetus, and subsequently in the offspring. We do know that EGFR inhibitors pass the placenta and also pass the best breast milk. So the lack of data is against the use of any of these inhibitors. Will you find a case report? Yeah, you will find a case report because we tend to publish the good cases, right? When we see the neurologic disorders after you use the ALK inhibitor, the provider is less likely to publish that. But I see them in my clinic. I have seen microcephaly secondary to alectinib. I have significant neurologic disorders, including spina bifida secondary to lorlatinib and the offspring. And EGFR, we have seen significant changes in the cardiac issues, including PFOs in the children. So at this point, based on the data available, do not recommend targeted therapy, particularly in the first trimester and second trimester. The third trimester is to be determined. But if you have a patient in the third trimester, I would recommend to do a bridge chemotherapy, in which we have years and years of therapy, and follow up, and then initiate. You will see me any day running to the delivery at Brigham. We have bottle of osimertinib, alectinib, selpercatinib 3 weeks ago. And I have given these women the pill before even the placenta is delivered. As soon as the baby is out, here's your pill. So you can use chemotherapy as a target to be safe. And I have a very honest conversation with my patients. I have a new mesothelioma that she was pregnant and she was diagnosed during IVF follow-up. And she decided to terminate the pregnancy, but we give her options. But I do not recommend targeted therapy because they cross to the placenta. And immunotherapy, let's stay back to immunotherapy. The PD-1, PD-L1 axis is to immune tolerability, right? That's what it produces. So when you disjoint the axis with immunotherapy, what is going to happen to the fetus, right? You can have a diffuse inflammatory response. Atezolizumab was only studied in immature baboons, sexually immature baboons. That's the only data we have in animal models, besides the animal models I did at Mayo. So we don't recommend immunotherapy either. Hasn't been a case report? Yeah, there's always a case report. There's always a case report about things. But we prefer to recommend things that are safe and get the woman to 33 weeks, assure pulmonary maturity, produce delivery. Usually we recommend C-section because it's a more controlled environment, but we are here. And then go for the Brigham and women high-risk OB. For Christmas, I'm buying them a card to each one if I could, because they're wonderful people. They're also challenging. Last New Year's, I ran the year in the ICU, had a patient that was pregnant with DIC, and I lost the mother and the fetus. We perised her twice, but the DIC was so disseminated, induced by the cancer. So no targeted therapy is recommended at this point. There's a way to do bridge chemo to get there. And the chemo that we use is a taxane. Yes, the taxane levels have been measured in the placenta, but we have more data long term. About the primary young lung, we have learned a few things with the preliminary data. Family history is very strong. Strong family history, particularly for Asian and Hispanic patients. That's what feed into equal, particularly for those patients. We have seen a high levels of ALK in the Midwest compared to the coast. We're trying to understand why is that happening. It's associated with the radon because we're more inside in the Midwest. We don't know. So that's what we have learned. No association with diet and exercise so far, but it has been hard to measure diet and exercise, to be honest, because everybody's very healthy at the time they complete the survey because they have been diagnosed with lung cancer.
Amazing. Well, yeah. Oh, sorry. I was going to jump in.
I'm just going to jump in real quick. Yeah. NJ, I know there's no time for questions, but I just want to say thank you so much. This was absolutely inspirational.
Oh, Brian had a question. Sorry, Jeff. Brian, you had a question before we head. I saw your hand. Thank you, Jeff. This is so cool that I will stay a little bit. I know that, huh?
Okay, only if you insist. Mine very quickly. Just with the home blood draw kits that you use, I'm curious the reception patients have to that and success.
So for young lung, the young lung has been very successful because they're coming home to them. And it's more expensive for the study. That's the drawback. But it has avoided traffic, it's avoided parking fees, and it has avoided register the patients in the hospital for the blood draw. Because some of them are not registered in the healthcare system, they're seeing care somewhere else. So that has allowed for easier recruitment to get. And we learn from the Premier Young Lung, and that's what we're doing it for Equal. So for Equal, we are suggesting family parties in which all the family members of the EGFR patients that qualify for Equal get together on a Sunday, and then we send the local phlebotomy team to collect the samples. It is more expensive. It's around 5 to 6 times more expensive than the blood draw, but at the end is to get to the patients. So if I do the blood draw at Farber with the blood test is around $58. We extend one, which goes to the patient's house, is around $360. But I hope in the party idea will help. I hope the party idea will help. We're equal, but for young lung, it has helped. Improve recruitment. You go to the patients. You don't want to add burden to them. You're already giving them a 200 questionnaire about where they go to high school, right? Where they went to high school, and then you're interviewing their mothers. Very interesting situation sometimes with the mothers. So
amazing. Well, thank you, Dr. Florez, so much again for your time and for staying well over the hour. I did want to just say during the presentation and for most of the Q&A, we had over 100 people listening to you, from high school students to undergraduates to medical students to doctors to family members and members of the community. So a really wide range, and we all really enjoyed your presentation. Before everyone hops off, we'd love to get a group photo. And if you're okay with it, if you could turn your camera on, that would be wonderful. And then Priyanka is going to snap a quick photo.
How can you put all these people in one picture?
Well, we're going to take a multiple and get all the
Okay, I was just wondering. I'm just wondering.
Yeah, and then by the way, NJ, I just wanted to acknowledge Jackie Nixon, who's the founder of a nonprofit focused on radon awareness, is here today. I think radon awareness is really important. So thank you, Jackie, for being here.
Where is Jackie? I don't see her.
She is on probably maybe the third page.
Jackie, we need to chat.
Waving, yeah.
We need to chat, Jackie. I work with Lara Mesquita, so we need to figure out what's going on in Monterrey. I think it's radon. Okay, I will be chatting.
Love to talk with you. Thank you so much for everything, though.
Jackie, we need to go to Monterrey. Something is happening there, and I think it's radon.
I'll put my email in the chat.
That sounds great. Let's go, girl. Let's do it together. We're gonna be there for a week.
Good.
All right, Priyanka, are you going to lead us?
She'll do.
You just tell us when to smile, Priyanka.
Yes, that sounds great. I'll count back from 3. 3, 2, 1. Awesome. Thank you. I have a couple of screenshots.
Can I have one last comment for the people on training? You are going to have the best job in the world. There is no better job to be in a healthcare provider. I will do it again because the trust that my patients put into me is something I will not take for granted. We're so lucky to have this job because you can change people's life just by listening to them. And that's free. Last time